Hello, this is Kim Jong-il. Today's lecture is the first part on expansion appliances, an introduction on expansion appliances and differential diagnosis. The expansion appliance includes an expansion screw. We can get 0.25 millimeter of space by turning the expansion screw once. The expansion appliance can be either fixed or removable. It is important to decide whether or not to extract during orthodontic diagnosis. For orthodontic treatment with non-extraction, we can obtain space in the following 6 ways. 1. Uprighting. 2. Derotation. 3. Expansion. 4. Labial inclination of the incisor. 5. Reproximation. 6. Adjustment of the occlusal plane. Among these, we discuss expansion in today's lecture. There are 2 main things we need to remember when considering expansion: whether the maxillary is narrow and whether there is posterior crossbite. If we have a transverse problem, we must first determine whether the maxillary dental arch is wide or narrow. Wide maxillary dental arch is often associated with deep bite. And there are many cases where the maxillary positions forward showing class 2 malocclusion. Narrow maxillary dental arch is associated with open bite, causing 3 possible results. First, since the maxilla is narrow, the midline deviation may happen. Second, a narrow maxilla with a mandible protruding forward may result in class 3 malocclusion. Third, the narrow maxilla may disturb the anterior growth of the mandible, resulting in class 2 malocclusion with a posteriorly positioned mandible. The maxilla grows first in the case of the normal growth and development. The mandible grows afterwards, and the maxilla and mandible become harmonious. If for some reason maxillary growth is insufficient, it may result in midline deviation or class 3 or class 2 malocclusion, as I commented. For cases of these 3 malocclusions, we must always first determine whether the maxillary is narrow or not. If the maxillary is narrow, consider applying an expansion appliance first for treatment without extraction. The maxilla is often narrow when there is a posterior crossbite. For cases of posterior crossbite, we must determine whether the maxilla is narrow or it is a wide mandible with normal maxilla. How can we determine if the maxillary is narrow or not? We can assess maxillary width in PA-CEF and CBCT. We can also evaluate it in the model. PA-CEF analysis measures the maxillary width, the distance between JR and JL points. We can also measure the nasal width in the nasal cavity. Ricketts claims that from the PA view, the maxillary width is 62.7 millimeters at the age of 8, and the maxillary width grows up to 70 millimeters for men and up to 68 millimeters for women. So you have to remember around 68 to 70 millimeters. The nasal CBCT distance extends from 26.5 millimeters to around 32 to 33 millimeters. Let's look at the PA view. In the left case, crowding is severe and posterior crossbite is observed. The nasal width is 32.9 millimeters, which is normal, but the maxillary width is 57.4 millimeters, which is quite narrow. In this case, we should widen the maxillary bone, even for adults. In the middle case, the nasal width is slightly narrow at 30.1 millimeters, and the maxillary width is 68.7 millimeters, which is sufficient. Therefore, tooth 6 and 7 do not display crossbite, but unilateral crossbite can be seen instead. In the right case, unilateral posterior crossbite is shown. The nasal width is 33.7 millimeters, which is almost normal. The maxillary width is also normal at 68.1 millimeters. As such, we must measure not only the midline displacement, but also the nasal width and maxillary width in the PA view. Next, the model analysis is important. Model analysis requires us to measure the intercanine width, transpalatal width, and the intermolar width, the distance between the mesiobuccal cusps between the first molars. When analyzing the model, we measure the maxillary intercanine width first, the TPW second, and then the intermolar width of the maxilla, the intermolar width of the mandible, and the intermolar width ratio in order. According to Professor Kim's thesis, for normal occlusion, the intercanine width is 34.07 millimeters for the maxilla and 25.87 millimeters for the mandible. And the intermolar width is 50.6 millimeters for the maxilla and 43.9 millimeters for the mandible. However, for unilateral crossbite, the maxilla is slightly narrower at 45.65 millimeters, but the mandible is normal at 44.5 millimeters. For cases of bilateral crossbite, the intermolar widths are normal at 45.2 millimeters for the maxilla and 44.6 millimeters for the mandible. In other words, there is no significant difference in the maxillary and mandibular intermolar width for unilateral crossbite. 1. Intercanine width. ICW, remember that the normal value of intercanine width is 34.1 millimeters. In the case above, the ICW is sufficient at 37.1 millimeters. On the other hand, the case below has a narrow ICW at 32.3 millimeters. It is possible to expand in the case below, but it is not recommended to expand in the case above. 2. Transpalatal width. TPW. This is the shortest distance of the gingival margin between the maxillary first molars. At the age of 7, it is around 32 millimeters, and by the age of 15, it grows up to 35 millimeters. In the upper case, the TPW is sufficient at 38.5 millimeters, whereas the lower case has a narrow TPW of 32.3 millimeters. If the early TPW is smaller than 31 millimeters, it can only grow up to 32 millimeters. Therefore, the TPW must be measured after the first molar erupts, and measured again around the age of 10 to 11, and expand the maxilla first if the TPW is small. The case above has a narrow TPW of 32 millimeters. The case below has a sufficient TPW of 35.8 millimeters. If TPW is sufficient like the case below, an expansion appliance is not required. 3. Intermolar width IAIMW. The intermolar width of the maxilla is 50.5 millimeters, and the intermolar width of the mandible is 43.9 millimeters. The case above has an IMW of 52.6 millimeters in the maxilla and 49.8 millimeters in the mandible. The normal value of the intermolar width ratio is 86.7%, but here it is 94.7%. This is a case with a wide mandible. On the other hand, the case below has a slightly narrow maxillary IMW of 49.4 millimeters and a wide mandibular IMW of 45.6 millimeters. This is a case with a small maxilla. Therefore, the case above has a wide upper arch, and the case below has a narrow upper arch. We must compare the intermolar width with the normal value and determine whether there is a problem in the maxilla or the mandible. In the case below, the maxillary intermolar width is 49.4 millimeters and the mandibular intermolar width is 50.5 millimeters. Therefore, the intermolar width ratio is 102.2%. The mandible is significantly wide. In such cases where only the mandibular IMW is large, there is a limit to treatment by only expanding the maxilla. When the maxilla is small, the anterior maxillary region may display crowding, and it is likely to be Class 3 malocclusion. We can treat Class 3 malocclusion without significant crowding in the mandible and only some in the maxilla with non-extraction treatment. We must check transverse problems for Class 3 malocclusion cases. Determine if the maxillary is narrow or the mandible is wide by comparing to the normal value. This patient has an intercanine width of 33.5 millimeters, which is slightly less than the normal value 34.1 millimeters. The TPW is 34 millimeters, slightly smaller than the normal value of 35 millimeters. The maxilla is slightly narrow with an intermolar width of 49.2 millimeters. The mandibular intermolar width is 50.1 millimeters, which is much larger than the normal value of 43.9 millimeters. The intermolar width ratio is very large at 101.8%. For the case of this patient, maxilla is slightly narrow and mandible is significantly wide. For cases of Class 2 malocclusion with nasal cavity and deep palate in the maxilla during the developmental stages, it is likely that there is a problem with the airway or that the patient has a finger-sucking habit. This leads to the narrowing of the maxillary dental arch, an interference somewhere, which eventually increases the chances of the mandible positioning posteriorly. Therefore, it is highly related to Class 2 malocclusion with a posteriorly positioned mandible. This patient has a large overjet. The profile is not bad. In this case, the patient is pushing the mandible forward. ODI 69, APDI 76, and CF 145 means Class 2 high angle. We can infer from the model that the canine relationship is half Class 2. Here, try to set the model of the mandible to be a Class 1 canine relationship and check the transverse relationship. How does it look with a Class 1 canine relationship? We can see that the maxillary premolar region is narrow. This is a case where the mandible fails to move forward due to the narrowing of the maxillary premolar region. In this case, the maxilla should be widened. Cases of narrow upper arch and posterior crossbite should be treated without extraction if possible. We can use expansion appliances or arch enlargements. Many people use expansion appliances. However, in Mio, the terminal molar is derotated first through. Then, the arch will be likely to expand. Cases can be classified by whether there is a posterior crossbite and whether the maxillary arch is narrow. Case A has a posterior crossbite and a narrow maxillary dental arch. Expansion is absolutely necessary for such cases. Case B has a narrow maxilla but no posterior crossbite. In such cases, the mandible is most likely trapped in the maxilla. Case C has a posterior crossbite, but the maxillary arch is not narrow. In such cases, there is likely to be a problem in the mandibular dental arch. Expansion is especially necessary for cases such as B, while some expansion of the maxilla and a narrowing of the mandibular dental arch is recommended for cases such as C. Case D has no posterior crossbite nor a narrow maxilla. In this case, the expansion appliance may or may not be used. It is only a big problem if there is a posterior crossbite. When we examine cases, we must always check first whether there is crossbite in the terminal molars. If there is a crossbite bite in the terminal molars during growing stages, we perform rapid enlargement followed by strategic leveling. For adult patients with posterior crossbites, we use mini screws or rapid expansion appliances with surgical operation. In recent years, it is recommended to use rapid expansion appliances including mini screws. If the terminal molars do not have crossbite, but the maxilla tooth 4, 5, and 6 do, and the maxilla is narrow, use RME with strategic leveling. If the maxilla is not narrow, I recommend SME. In a similar sense, if there is crossbite in the posterior region and the maxilla is tapered arch form, use a slow expansion appliance with strategic leveling. If there is no posterior crossbite and the maxilla is not tapered arch form, only use strategic leveling. In summary, it is necessary to determine whether the terminal molar has crossbite, whether the lateral tooth group has crossbite, and whether the maxilla has a narrow dental arch. Before using expansion appliances, we must first evaluate the crossbite and mesial rotation of the terminal molar. If the terminal molar is mesially rotated, perform strategic leveling. If it is in parallel rotation or has posterior crossbite or has a narrow maxillary dental arch, use an expansion appliance before strategic leveling. Thank you for watching.